Okay, so we are doing type 1 diabetes. So I'm just going to share the screen here. Okay, so type 1 diabetes, we're going to talk about just what that is in general. So
Type 1 diabetes, also called juvenile onset diabetes or insulin-dependent diabetes, accounts for 5 to 10% of all diabetic cases. When it comes to type 1 diabetes, the pancreas just does not produce the hormone insulin anymore. And this is because of the destruction of the beta islet cells that are in the pancreas. And these are the cells that are responsible for producing the insulin that we use in our bodies.
Okay, and because we can't use the insulin, there's going to be an increased amount of glucose in the blood. And this will cause the three main symptoms, which are polydipsia, excessive thirst, polyuria, which is excessive urination, and polyphagia, which is excessive hunger. The amount of glucose in the blood causes a hypertonic situation, which draws out water from your cells, making them feel dehydrated, and that triggers the thirst. The water drawn out along with the high glucose also causes high blood pressure, so your kidneys will try to alleviate that by filtering more of it out, causing the frequent bathroom visits. And since the cells cannot use the glucose in the blood due to lack of insulin, the body thinks it is starving, so it triggers you to want to go eat. And if your blood sugars go too high, it causes something called diabetic ketoacidosis, which is a complication where your body thinks it's starving. It has no glucose, so it starts breaking down your fat to use the fat as energy. And since ketones have a high acidity, it will lower your pH and cause metabolic acidosis. And some signs of this is deep and fast breathing, nausea and vomiting, dehydration, dry skin and dry mouth. Ketones usually have a fruity or sweet scent to them, so your breath, body odor, and even your urine might start smelling sweet. It also comes with headaches and muscle aches, and along with the three big P's and all the other signs and symptoms of diabetes.
and here are some other complications listed. We'll be reviewing these throughout the rest of the presentation. So we're going to look at hyperglycemia now.
When someone does not treat their blood sugars with their insulin, they can get hyperglycemia, which is high levels of glucose in the blood. Some of the symptoms that come with hyperglycemia can be malaise, which is just a general feeling of not feeling well. There can be nausea and vomiting, the fruity smelling breath from the ketones being broken down. There can be weakness, abdominal cramping, and if severe enough, a person can go into diabetic coma. And on the opposite end, if someone overuses medications like insulin, they can have hypoglycemia, which is glucose in the blood. And this can have sweating, clammy skin, hunger, irritation, shakiness, confusion, disorientation, headaches, stupor or loss of consciousness, and if serious enough, seizures.
Okay, great. So now we're going to look at some diagnostic criteria for diabetes. There are several ways that diabetes may be diagnosed. An oral glucose tolerance test is where the patient is given 75 grams of a glucose dissolved in water. The patient's blood glucose is taken before and 2 hours after consuming the solution. And depending on the blood glucose level, 140 to 199 milligrams per deciliter may indicate prediabetes. 200 milligrams per deciliter or greater may indicate diabetes. A glycogated hemoglobin test, or an A1C, is a test that measures the percentage of glucose that has entered the blood cells and adhered to the hemoglobin. The A1C represents the average blood glucose spanning over 2 to 3 months, and 5.7 to 6.4% may indicate prediabetes, and 6.5% or greater may indicate diabetes. Fasting plasma glucose levels greater than 126 milligrams per deciliter on 2 separate days may indicate diabetes, and there may be a presence of glucose or ketones within the urine. These tests should be performed within 2 consecutive days for a reliable diagnosis of diabetes. So how do we determine type 1 from type 2? That's my question.
So there are a few tests that can do that. The basic difference between type 1 and type 2 is that type 1 is when your body can't make any insulin, and type 2 is where the body may still be able to make insulin, but the body cells cannot use it as efficiently. Since type 1 is an autoimmune disease, your immune system will attack the islet cells that make the insulin, so the presence of these autoantibodies can help distinguish between type 1 and type 2. Another test is the C-peptide test. This works because when your pancreas secretes insulin, it will also secrete C-peptide. So if there is high levels of C-peptides, then there's high insulin secretion, and if the C-peptide is low or none at all, then that can indicate little to no insulin secretion.
Huh.
And that's how you kind of distinguish between type 1 and type 2.
So I have a question for you, Jack. It's somebody with type 1, are they going to be diagnosed usually later in life or earlier on in life?
So it's since it's usually it's also like genetics, and because it's an autoimmune, it's usually young adults, probably even before 18.
Oh,
I think it was like before 40 years old, most people get diagnosed with type 1 before they're even 40.
okay.
So, and then
Excellent.
type 2 is more of a later stage kind of
Great.
thing.
Great. Okay, so we're going to go ahead and look at some treatments here. And so the main sort of treatment that we're most familiar with is insulin.
Yeah, so there's actually many different types of insulin. It might get a bit confusing. So there's going to be fast and slow insulins, but the slow has short and rapid acting insulins, and the fast acting insulins, the longer acting insulins is distinguished into intermediate and long acting. Generally, the plan is individualized. No two people would have the same insulin therapy. It's also dependent on diet and exercise and a lot of other factors. So it's going to be different for everyone, but generally the plan is to have 1 or 2 long-acting injections per day, along with supplemental short and rapid-acting ones with meals, or depending as needed during the day. If you go into that,
These faster onset insulins, we have a rapid acting and a short acting. So with that rapid acting, we have Lispro and Aspart. And the onset for the rapid acting is generally 10 to 30 minutes, with a peak of 30 minutes to 3 hours and a duration of 3 to 5 hours. And then short acting is just a little bit quicker than rapid acting. So we have regular.
So these two, you usually take it before a meal, because they'll start working by the time you start digesting your meal.
And then kind of just the over the time span of the day, we're going to be seeing the intermediate acting and the long acting. So for the intermediate acting, we have the NPH, onset 1.5 to 4 hours, a peak of 4 to 12 hours, and the duration 12 to 18 hours. And we have long acting, which is Glargine, Detamir, and Tresiba. I think I pronounced it right. Tresiba, yeah. So this one is interesting. Onset 1 to 4 hours, and the peak, there's actually no peak, and the duration is 16 to 24 hours. And that no peak, just a long, super long, so long acting that the peak is so flattened that it's just this linear gradient across the day that kind of maintains the glucose levels.
To keep like a nice baseline going.
Yeah, exactly. Yeah. Okay, so we're going to talk about some other medications in addition to insulin, and of course, diet and exercise.
So there are medications out there that help the pancreas secrete insulin or help the cells use the insulin, but sadly that is for type 2 diabetics. For type 1 diabetics, it's just insulin that we use for treatment. However, due to comorbidities that can occur from type 1 diabetes, medications that help with high blood pressure, cholesterol, and aspirin for the heart can be prescribed.
And as a last resort, it would be a pancreas transplant.
Yeah, so the pancreas transplant, I just kind of found out about this. I mean, I knew about pancreas transplants, but you can actually have an islet cell transplant within the pancreas. But as Jack mentioned, it is definitely a last resort.
Transplants are major surgeries. We try to avoid those as much as we can.
Yeah,
So,
yeah, exactly. Kind of moving from the least invasive to the most invasive. So we're going to look at some nursing assessments, interventions for a patient with type 1 diabetes.
So one assessment you'll be doing is a blood glucose. And this is when you prick the finger to get a drop of blood, and then you use a little handheld machine that sucks up the drop of blood, and it will read the amount of sugar in the blood. Another one is the A1C, which again, it looks at the blood sugars over the past 3 months. And this is because red blood cells live for 120 days. So they picked 90 days just to hopefully get a good estimate. And then also, since diabetic people can have neuropathy, this is like some of the symptoms is like not being able to feel that area of the body, and there can be tingling. And this is from nerve damage. And so they might not be able to feel something such as like a rock inside their shoe, or that their shoes aren't fitting properly, or that like blankets and stuff being on top of their toes is like giving them little pressure sores. So you should be assessing their lower extremities. Another is kidney function test. Because glucose molecules are so large, when they are going through the kidneys to be processed and urinated out, they will ruin and damage the nephrons of the kidneys.
Yeah, so we kind of already talked about diabetic ketoacidosis as an acute complication of hyperglycemia, but we're going to kind of look at the nursing interventions of what to do when a patient is experiencing diabetic ketoacidosis. Initial interventions for the patient with diabetic ketoacidosis is going to start with an assessment of our ABCs. So we're going to ensure the patient's airway is patent. We're going to maintain oxygenation by giving oxygen therapy. We're going to look at their circulatory system. We're going to establish IV access with a large bore catheter to begin fluid resuscitation with normal saline at around 1 liter per hour. Once the blood pressure has been stabilized and the urine output is at 30 to 60 milliliters per hour, we're going to begin a regular insulin drip depending on the patient's weight per hour. And then we're going to be looking at, we're going to continue to monitor vital signs, level of consciousness, cardiac functions with an ECG, oxygen saturation, and urinary output. We're going to look at breath sounds for fluid overload, because we're going to be giving a large amount of fluid. So we're going to be looking for pulmonary edema. We're going to monitor serum glucose and serum potassium levels because insulin can, in addition to uptaking glucose, it can also uptake, the cells can uptake potassium, which may lead to hypokalemia. So we may need to administer some potassium to correct for the hypokalemia. And then we're also going to see with diabetic ketoacidosis, as Jack mentioned, we're going to see ketones, which are very acidic. So for severe acidosis, we're going to give sodium bicarbonate as an antidote. And then to ensure that the adverse effect of hypoglycemia doesn't occur, we're going to give an IV fluid of dextrose to maintain the glucose levels. And then for a hypoglycemic event, it's going to depend on the consciousness of the patient. So for the conscious patient, we're going to enact the hypoglycemia protocol and use the rule of 15. So if the patient's blood glucose is below 70 milligrams per deciliter, we're going to administer 15 grams of a fast-acting carbohydrate, such as 4 ounces of orange juice or apple juice. We're going to wait 15 minutes. If that blood glucose hasn't been stabilized, we're going to repeat that around 2 to 3 times. And if that hasn't corrected the issue, we're going to call the provider and expect an order for 50% dextrose in water. And we're going to give 1 milligram of glucagon intramuscularly if we can't establish an IV access. So yeah. So then we're going to kind of move into patient education.
And
we're going to look at diet.
So one of the biggest reasons why managing blood glucose level gets difficult is because insulin therapy, diet, and exercise all work in tandem with each other. Increasing or decreasing in one aspect will require adjusting the other two to maintain homeostasis. So keeping a regular schedule is best. As for diet, you can still eat carbs. Carbs are a source of energy and you need that energy. But the foods to avoid are saturated and trans fats. And general guidelines are to eat more vegetables and less red meats. Try to replace your sugary drinks with water and to limit alcohol and smoking. Another thing to note is that you should probably get familiar with the glycemic index. It is a way to categorize foods by how fast they raise your blood glucose levels. So the lower the glycemic index of a food is, the better they are for longer sustained energy. And then that's the diet portion. And then again, in tandem with it would be exercise.
So exercise will help move glucose into cells. And since exercise will lower blood sugar, you'll want to make sure that when you are going out and exercising, that you have a snack on hand just in case your blood sugar does get low. So like a little orange juice box or granola bars or a little candy bar, even though you're exercising, but that can't hurt. You want to definitely watch for the hypoglycemia. And it's recommended to do 150 minutes of moderate exercise, 30 minutes, 5 times a week, and to try and aim for a BMI between 18 and 25. And will help lower the risks of complications from diabetes.
And it'll also lower the risk of getting type 2 diabetes if you don't have diabetes.
Yeah. Okay, so now we're going to kind of look at the insulin injection. So usually an insulin injection is subcutaneous, or it is subcutaneous, which is at a 45-degree angle under the skin. And so it's important to, not use the same needle more than once, and basically gently pinch a lump, just a lump of tissue, and inject that into the tissue underneath the skin. So some common sites are the abdomen, back of the arm, the thigh, and it's important to make sure that the patient rotates sites to avoid lipotrophy.
You just don't want to stab yourself in the same spot multiple times.
Exactly. You want to avoid that skin breakdown, that buildup of scar tissue, because it can be more difficult to give yourself an insulin injection as well.
And lastly, we have doing CVGs. So there are many different devices out there. So you'll definitely want to read how to use your specific device, as well as like if you're doing one in the facility, you'll want to follow your protocol. But basically you have the device, and then there's the little test strips that will suck up the blood and the little lancets. You'll want to wipe off the finger that you're going to use and let it dry. You can use an alcohol pad, or you can use a washcloth with soap and water and all that stuff. If they have cold hands, you'll want to if you have cold hands, you'll want to get them warm. And then you'll want to poke on the of your finger. You don't want to poke on the pad of your finger, because that can damage the nerves on your finger pads, and it will cause you to lose feelings in your finger pads. The first drop of blood that you get, you're going to want to wipe it away, and then you're going to wait for the second drop, and then you will use that drop to do the reading on.
Why are we wiping it away? Wiping the first? Wouldn't that be the freshest drop of blood?
Well, because it's contaminated with other things, Jack.
Oh, okay. And then I have a question for you, Cierra. So for this image here, is that the right spot to do the lancet?
That spot has a heart because you're giving love to that part of your finger by not poking it.
Okay. With the pokey thing.
Genius.
Great.
Yes.
Okay. Awesome. Okay. Great. And then we have some references here. Great. All right.
Thank you for
And
coming to our
that's
presentation.
type 1 diabetes.
Till next time.
Thank you, guys.
Thank you.